We're very pleased today to have with us Dr. Emmanuel Bosi, coming from the San Raffaele Hospital in Milan, Italy. He's going to be discussing the Italian law on screening for type 1 diabetes and celiac disease in the general pediatric population, an update at fall 2024. And a little bit about him. He's a physician scientist. He's a professor of internal medicine, formerly of endocrinology at the San Raffaele Vita Salute University. Currently the head of private medicine department in the diabetes and hepatology units at the San Raffaele Hospital in Milan. He graduated in medicine from the University of Milan, Italy, where he received a specialty diploma in diabetes and metabolic diseases, and afterwards in clinical immunology. He trained at the medical clinic of San Raffaele, and he worked as a clinical research at Edward Herriot Hospital in Lyon, France. Just letting some people in. His research activity has been entirely devoted to diabetes, covering several topics, namely autoimmunity associated with type 1 diabetes, with reference to disease mechanisms and the use of autoantibodies for prediction and prevention of the disease. In this context, he created the San Raffaele, the JDRF TrialNet International Center, which operated from 2004 to 2019 and evolved into Anodia Harvest and Anodia, finally the FID Anodia Center. The group, as of 2023, the group is a partner of Eden T1F1 and Pre-T1D European Registry, all UE-funded. TrialNet, Enodia, Eden T1F1, and Pre-T1D European Registry are international consortia investigating the natural history of type 1 diabetes, screening for the identification of pre-symptomatic cases of type 1 diabetes, and conducting interventions and aimed at delaying the clinical onset of the disease. In 2023, Dr. Bosi contributed to the design and approval by the Italian Parliament of the law for nationwide screening for type 1 diabetes and celiac disease in the pediatric population of Italy. And he also coordinated several clinical research groups over time with expertise in conducting trials on the treatment of T1D, T2D, and chronic diabetes complications, and as well as the use of innovative technologies and integrated systems for blood glucose monitoring and prevention of hypoglycemia. He's published over 2,200 scientific papers, and we're very pleased to have him here to kind of walk us through the process, the Italian process, for getting this type of screening going, and the process of getting it made into law. Thank you so much for joining us. We're looking forward to this presentation.
Thank you, Monica. Thank you all for the invitation and for the opportunity to talk about the Italian law on general population in pediatric age. This has been a significant achievement, and was in a way, it was dictated by the need to overcome the usual obstacles, the historical obstacles we had in Italy. You know, as you mentioned, I was part of TrialNet, which is a consortium based basically in the United States with some international satellites. And over 15 years, I tried to build a network of satellites, and basically I failed. I failed because there was no public perception and diffuse skepticism about science, no dedicated infrastructure, few people really believing in type 1 diabetes research, and also Italy is a quite complicated country, perhaps exactly as the others from the legal and political point of view. And also we chronically suffer from limited research funds. So the idea was to overcome all these by trying to establish a law dictating the screening incorporated into the national health system. And this action was possible also thanks to the advocacy of many people, mainly by Fondazione Italiana Diabete, which is a charity devoted to fundraising to type 1 diabetes. And to make a long story short, what was surprising was that thanks to the help of this gentleman in the center of the slide, who is Mr. Moulet. He's the vice chairman of the Italian Parliament, and he believed in this, and he helped us a lot, drafting and then putting forward this law that in a very short period of time, about 6 months from the first presentation to the final approval, and this is the official journal of the Italian Republic reporting the law, and the law was basically the nationwide screening for both type 1 diabetes and celiac disease in the pediatric general population of Italy. The general objective was to do the screening in order to identify individuals at risk or in early phase of type 1 diabetes, and at the same time to identify people with undiagnosed celiac disease. And the aim was to reduce the complications associated with the later diagnosis of this disease. And among complications, the most important and dangerous is DKA, diabetic ketoacidosis, which has a very high incidence in Italy as well as in many other countries. Think that about from 30 to 40% of childhood diabetes in Italy at the onset have this complication, diabetic ketoacidosis, which requires hospitalization and in some instances even hospitalization in intensive care unit. And also the fact that in addition to the possible prevention of DKA, through screening, it is possible to identify individuals with type 1 diabetes in their pre-symptomatic phase, which are suitable to receive disease-modifying therapies. And from the celiac point of view, of course, the recognition of those who have the disease but who are not diagnosed due to perhaps the mild or absence of associated symptoms, this may allow a prompt treatment which consists in the removal of gluten from diet. And at the same time, this allows the prevention of non-gastrointestinal complications of celiac disease, including, for instance, impaired growth or short stature. Immediately after the law approval, the Ministry of Health designed and asked us to implement a propedeutic, this is the exact translation from the Italian law, but we can read it as a pilot study on a smaller scale to assess feasibility, acceptability, and sustainability within the national health system of this program of screening. And the time of conduction, we started in April, and we are close. I mean, instead of November, it will be December. But we were able to perform this pilot, which is very informative. This pilot was on a sample with only 4 regions participating. The children to be screened were a little bit more than 5,000, and there were privileged screening ages, which are at the age of 2, 6, and 10 years, based on evidence from literature that these ages correspond to some peaks of seroconversion. An innovative aspect of this study was the fact that the operating network was that of family pediatricians. In Italy, we have a fantastic network of pediatricians who are basically GP, and any child or adolescent in Italy has the right to have access to a pediatrician within the national health system. And other aspects, the screening test was done on capillary blood obtained after finger prick. And on capillary blood, it was in this pilot study performed the measurement of the type 1 diabetes-associated antibodies to GAD, IA2, zinc, and insulin, and the celiac-associated autoantibodies transglutaminase, IgA, and IgG. In addition, we also performed the HLA, DQ, and DQ8 typing on cards. And these are other aspects. And to make this more clear, this indicates, the slides indicate the 4 regions participating to this pilot study and how the children were distributed according to the region and the age. Corresponding, of course, the ages, as I anticipated, to the report peaks of seroconversion. Another aspect which is obvious, but I just want to underline that this distribution was done according to the general population demographic data. As I anticipated, a trait, really a specificity quite unique of the study is the fact that the screening is, in practical terms, executed by family pediatricians. Family pediatricians in Italy are part of the NHS, and they correspond to a nationwide network. They are by law responsible for prevention, cure, and habilitation in the age range of 0 basically to 14 years, but in some cases up to 16 years. And in this study, family pediatricians were responsible for many things: the direct contact of families, the presentation of the project, the administration of all informative materials, and of course, the informed consent, the practical execution of capillary blood drawing by finger prick, blood collection, either in microtubes and cards, preservation of samples, and then shipping by courier, and then to administer, to communicate to families the results of the screening when they receive it. And finally, we are testing the feasibility and acceptability also on the side of pediatricians by administration to pediatrician-specific questionnaires. And here you see the capillary blood is obtained from blood after a finger prick. You see the figures, how it works with microtubes. Is relatively simple, but I mean, not so simple from small children. And in addition, we are collecting 2 drops of blood on paper. The assays, both autoantibody measurement and genetic typing, are performed centrally at the San Raffaele Hospital. And we already shown in a previous study on the general population that universal screening conducted by capillary blood in comparison with venous blood was preferred, much preferred by participants to the screening. And here you see the flow chart starting from the family pediatrician who are executing the screening, and then the central lab is receiving samples and is performing autoantibody measurement by, in this study, by both ELISA and LIPS, which is an immunoprecipitation method. which is a method developed in research, very, very sensitive and specific, while ELISA is a commercially available technique, easy or relatively easy to perform by a good hospital lab. And so among the objectives of this study is also the comparison of the performance of these two methods in a large screening sample. On the celiac disease side, we did exactly the same, measuring transglutaminase autoantibodies by a commercial ELISA and then by a similar LIPS methodology. Of course, all the data were protected. Participants were pseudo-anonymized, and also participants were asked if they agree or not to participate to the Identify European Consortium study, which is collecting individuals identified as at risk from many countries in Europe in order to create a large number of people for research, available for study research, or also to participate to clinical trials or innovative therapies when available. And on the type 1 diabetes track, let's say, of course, people who were negative to the screening, they were not participating to the study anymore. Any positivity had to be confirmed by a second sample, and then individuals, basically children, identified as at risk for type 1 diabetes were referred to the pediatric expert regional center in order to do follow-up, staging of the disease, follow-up, and monitoring. On the celiac track, people identified as positive for antibodies, if confirmed, were referred to more or less the counterpart of type 1 diabetes center, celiac disease pediatric expert regional center, who are performing the confirmation of the diagnosis and the start of a gluten-free diet. The follow-up and monitoring is an argument which has been, for instance, very well addressed by a consensus, by a recommendation paper by JDRF and other major societies, recently published in Diabetes Care and Diabetologia, and also the Italian panel of experts made their recommendations, which include, of course, always the same, because which is the measurement of glucose in different conditions, fasting glucose, random glucose, or glucose after an oral glucose tolerance test, or glucose during the 24 hours measured by continuous glucose monitoring, that is by sensors, which are now widely available. And this is the most important aspect of monitoring, because once you identify an individual having 2 or more among the 4 autoantibodies, we know that the risk of developing clinical type 1 diabetes is very high. And therefore, from that point on, it is important to further quantify, to further assess the risk of progression. And the risk of progression from the different stages, stage 1 and stage 2 to stage 3 of pre-symptomatic type 1 diabetes, the most important monitoring values are those related to glucose. In addition to metabolic, let's say, glucose monitoring, in the preclinical monitoring protocol, a fundamental part is education, because the people who are instructed and who are aware of the fact that a child is at risk for developing type 1 diabetes, they are made aware about symptoms, early symptoms such as polyuria, polydipsia, weight loss, fatigue, and so on, which are all preliminary and early manifestation of clinical diabetes. And these are alarms and indicators that insulin therapy has to be initiated. Of course, if the family is already aware of all these, the recognition of clinical aspects just preceding the clinical onset and the need for insulin are well recognized, while in most of the families where there is no history for the disease and no education about this aspect, the diagnosis of type 1 diabetes is always late, and that's why the incidence of diabetic ketoacidosis is so high. And therefore, and there is another aspect which need to be investigated, and it will be in the study, which is the impact, the psychological impact of screening, and also of possible communication of positivity, meaning that that children is at risk for type 1 diabetes. This, of course, has a psychological impact on the family. This is very well known. However, this matter needs to be more in-depth investigated, and this is done in the study. Just to make you, to make an update of this study, these are the data at the beginning of November, few weeks ago, and most people were already screened of the original target. So we are confident, and we are indeed in these days ending, with the last people of participants. So we are confident to reach the target before the end of this year. And as I told you, there are 4 regions participating, and this is the frame at the end of July. You see that the Lombardy region already in a couple of months did most of the screening, while in the opposite, Campania was more difficult. And of course, we are trying to understand which were the reason, and I'm happy to say that now also the other regions, Sardinia and Marche, almost completed, as well as Lombardy, and also Campania is recovering very fastly. And this is a quite reassuring information. And these are just preliminary, very preliminary results, just to indicate that by the commercial ICA ELISA screening, we found 0.7% of screened children positive for this test. And of these, 0.3% of people confirmed to have a single antibodies, while 0.2% demonstrated to be positive to multiple autoantibodies. And the positivity for multiple autoantibodies corresponds to a very high risk, which in children almost correspond to certainty to develop clinical type 1 diabetes within a few years. So another aspect which was very important, and we added to the study through an amendment, is represented by questionnaires. Questionnaires developed within the Identify European project. And these questionnaires were investigating basically anxiety, depression, and quality of life of families participating to the screening, and tested before the screening and after the screening. And again, the focus was on anxiety, depression, and quality assessment of quality of life. So to make a summary, the new Italian law on screening type 1 diabetes and celiac disease has passed, and the pilot study investigating the feasibility and acceptability items is almost concluded. The initial feedback are the following. First, and most importantly, the law was very well received by not only the scientific community, but also the Italian community in general. The Italian government, through the Ministry of Health, really reacted very early, and they asked us to conduct this pilot study, which is very informative. I mean, we didn't conclude yet, but so far the response was really fantastic. Honestly, I didn't expect to be so successful in this pilot study, and this we have to thank for these family pediatricians and families, indeed. Of course, there are a number of feedbacks which are critical for feasibility and acceptability. I think the most, the real obstacle, we didn't imagine this, to be honest, when we started, are technical difficulties in drawing blood, capillary blood. Because we consider the capillary blood drawing a very simple procedure. And indeed, it is very simple if you perform it in the hospital. And this is done by professional physicians or research nurses, very, very expert in that. But, you know, it's not the same for a single family pediatrician in his or her office without help. And indeed, the most relevant difficulty was the technical one, which consists in being able to collect capillary blood into microtubes. So we created a number of tutorial videos which helped a lot. And so at the end, we were successful. And the second issue is now we concluded the pilot study, and by law, the responsibility of the screening has to move from the central Ministry of Health to the peripheral regional authorities, which in Italy are 20. And, you know, we are worried because it's not simple to make all harmonized and homogeneous. However, we will see the fact that the pilot was so successful is a precondition for the national general program to be successful as well. And by thanking all the people participating to this very huge effort, I wish to thank you for listening to me tonight. Thank you.
Thank you very much for walking us through this process. We have a number of esteemed people in the audience, scientists and scientist physicians, and I'd like to open it up for them to ask more questions or ask questions. They can drop something in the chat or they can unmute themselves.
Monica, I have a couple questions for Emmanuel.
Yes.
While you're
good.
waiting. Hi, Emmanuel. Alexis, thank you so much for that presentation. It's really exciting to hear about the success that you've had with this pilot program. I had a couple questions. The first did you have any difficulties with consenting
Well,
parents to have done with and what was the consent rate?
Well, in this, the pilot study is biased because we asked the family pediatricians who were available and willing to do, and so in turn, the pediatricians asked among their families who was willing to collaborate. Of course, there was the selection according to age. So based on this, the rate of acceptance was very high, but it would be high in any case, so by definition. So I can tell you the rate of acceptance was high, but was based on voluntary participation. Having said that, also in the law, it will not be mandatory, the participation to the screening. So families who are unwilling to participate, nobody is obliging them. However, also as a general perception, we were quite surprised by the fact that despite the general meaning that there is skepticism against science and so on, the no vax, the no everything, in the society. At the end, the large majority of common people, of common families, seem to be quite willing to participate to this. They were interested. In general, and this is surprising, and this is one of the reasons why we combined the screening of type 1 with that of celiac disease. The impressive aspect is that almost everybody knows celiac disease, at least in general terms, while very few people know exactly what is type 1 diabetes. This is a general problem. Type 1 is normally confused with type 2 diabetes. When you talk about diabetes to people, the classical response is, oh, yes, my grandfather, I remember when I was a child, my grandfather was suffering of diabetes. So specific culture and knowledge about type 1 is not so diffused in Italy. But while, I don't know why, they know much more about celiac. But in general, families are interested and willing to participate. I cannot give you the dates exactly, but
are those children coming in for general wellness checks and vaccines at that time? And are they also getting blood drawn for, say, a hemoglobin anemia screen at the same time?
Well, I'm unable to answer because in my personal experience, a few years ago, when I was trying to put forward general screening, I contacted the authorities, and in my mind, I had the idea to exploit vaccine procedure in order to take the opportunity to do the blood drawing. But I was unable because they explained, in Italy, unfortunately, people are quite rigid. Since the law prescribes vaccination, vaccination is not the blood, it doesn't include the blood drawing. This I was told. And so we are sorry, Dr. Bosi, but you cannot exploit the vaccine center in order to do the screening for type 1 diabetes. This was the answer I got a few years ago when I tried. That's why we thought about the network of family pediatricians and, of course, the capillary blood collection. And at the end, this was successful. Why, at least my personal approach, maybe I did wrong or something, but in my personal approach, to the Italian health authorities, and in order to exploit the vaccination campaigns, which are working well, and the answer I received was not possible. And so maybe in other countries it works better, but personally I failed this, while we were successful exploiting the family pediatrician network.
Manuel, can I ask a quick question? Just sort of turning the page and talking a little bit about costs. So in 2022, Annette Ziegler and company published some of the results from the FRIDA study in diabetes care. And that publication was cost of public health screening of children for pre-symptomatic T1D in Bavaria, Germany. And that cost per child screened in FRIDA was €28.17. And so for US, it would be $29.60. And what kind of costs were you guys seeing, or could you see that cost associated with this program?
Well, in fact, we used exactly that paper from the FRIDA study. And when we were talking with the ministry, I said, well, the only similar study for Italy useful to estimate cost is the FRIDA study. So I told them and convinced them that with around 30 euro per sample, of course, without calculating all the infrastructure exploiting, but considering also a small incentive of 8 euro for single sampling for pediatricians, because Annette Ziegler, who is conducting the FRIDA study, told me personally about the keys for success. There was this little incentive to pediatricians, so we did exactly the same. And so the final costs, I cannot tell you now because all the balance has to be done. However, the estimate was exactly the same. And I'm convinced, of course, I was very much criticized by many colleagues who said, well, this is totally unrealistic. The costs are much higher. And it all depends on the scheme you follow. If you, in my opinion, and we will do the balance of this pilot study, but we didn't receive much money. So at the end, there was some further support that we used for measuring antibodies and HLA typing. But at the very end, I think that the cost is not much higher than 30 euro per single child. While some other people, claim that is more the double or the triple the real cost. I will tell you, but I'm quite optimistic. It all depends on what is the procedure. If you exploit family pediatrician network, you do the capillary blood sampling, you use, one of the most expensive items was shipping, because we used courier, of course at room temperature without refrigeration, but it is expensive. But the recommendation was that pediatricians were accumulating and not doing a single shipping for a single sample, because sample could stay in the fridge for a few days without deterioration. And the cost
if we go, oh, sorry.
No. And the cost of antibody measurement, we know, which is not very high, is about 10 euros, 12 euros, something like this. Then you can negotiate, of course, with because we did the primary screening was based on the commercial RSR ELISA for the 3 screening. In addition, we did, but this was for research purposes, also the lips, but this was just to compare.
So I had a quick question also. So if you circle back to identify with the 3,651 patients, and then you identified 6 as multiple autoantibody positive, of those that you identified, maybe even the 9 with the 1 autoantibody and the 6 with the multi-autoantibody, are you suggesting or discussing the use of teplizumab with those patients?
Well, probably yes. I mean, the overall prevalence is about, I mean, in Germany and other countries of multiple antibody positivity is 0.3. We found 0.23 more or less in this slide. This was not updated. Anyway, we found a little bit lower prevalence of double antibodies than in Germany. Of course, teplizumab will become available in Italy in a few weeks. There is an agreement we can use for, you know, there is this procedure for compassionate use. This is called like this. And in practical terms, this is meaning that the drug is paid by somebody, I suppose by the company, while the NHS should provide the infrastructure. And this will be possible only for children aged 8 years or more, which is exactly as in all countries, I suppose. Perhaps in US can be used in earlier ages. And our intention is to propose teplizumab in these people, those who correspond to stage 1 or stage 2.
Got it. That will be an interesting group to follow. I'd like to open it up. Any more questions? Anyone else?
Hello, can I ask a question? This
Yes.
is Georgia.
Thank you, Georgia.
Hi, Georgia.
Hi, Professor. Excellent discussion, and thank you so much for all the work that you have done. So I would like to ask you a question about the next step. So how are you going to transition now from this pilot program to nationwide adoption? And how is it going to be implemented? Thank you.
Well, officially, and now, I mean, as I anticipated, the problem of the organization will be based on the NHS organization in Italy, which is according to regions, so is a little bit fragmented. And this worries me a little bit because a single region have not the good infrastructure, I mean, the good organization, let's say like this, of the central ministry. However, the NHS in Italy, more or less, despite the critics, is working well. The problem with this screening is that is a total novelty compared to what is existing. We have a number of screening, neonatal screening, but after that, we have vaccination programs, but this is going to be a novelty. And however, so I cannot answer you because we are working on that. We have some tables with panels, with discussions, and there is a good, I mean, everybody is always saying, well, but we have not enough money. I mean, this is the usual argument that they, and so we will see. We asked more money, apparently we obtained, but we are always talking about a relatively small, I mean, a few millions for the entire screening. However, I mean, the crucial aspect is now, the good news is that they all accepted the fact of the possibility to revise every year the procedure. So if what we will implement now, in 1 year we will review, and change, we have the possibility to change. And I think this flexibility is very helpful. My general feeling is that basically the most important obstacle is that the people with whom we are talking, they really ignore what we are talking about. And so it's a fact of a little bit more time to be invested to convince people, to educate people, to inform them. But apart from consuming our time in all these calls, tables, and so on, at the end, I think that we will succeed because I found in any case a good position. I mean, nobody is against. They claim, they say that they have not enough money and so on. But this, we know perfectly, is the usual argument. We are used to that. So,
Dr. Bosi, let me ask you, so from the success of this pilot, what is your opinion in terms of how a very complex, insurance-driven, private paying, situation like the US have, the healthcare system in the US, how might what you've done here translate into a US screening system? Or do you feel that, or do you think that it's kind of a big stretch or impossible?
well, no, I mean, as I told you, the key of the success were pediatricians. Well, in US, you have private pediatricians as we have public. But probably private pediatricians should receive a fee which is higher, but it is not impossible. I would suggest to do exactly the same. And the difference is that you will rely on private rather than on public pediatricians. But the screening based on the capillary blood drawing can be done in the doctor office and sent by courier or even by regular post. One aspect which could increase a lot the feasibility would be to rely on assays using cards instead of the capillary tube. Well, there are assays which are working on cards, but we know that the sensitivity is lower. So it's a matter of, accepting a reduction in sensitivity towards a much higher feasibility. What I hope is that one day in the near future, if somebody is able to optimize the measurement of autoantibodies from cards, dry filter paper, this would help enormously, really. It's a technical aspect, but it is crucial. And my suggestion, I mean, according to our experience, I don't see impossible to translate the same procedure to US using private instead of public pediatricians. And the rest, of course, you need to organize centralized labs, regional labs with all the expertise, but this is not certainly a problem in US. And so I'm not so, I mean, I'm quite optimistic, but the keys are pediatricians, family pediatricians, and capillary blood.
Thank you very much. Last call for questions or from, oh, here's a question. You mentioned that an HLA test is done on each blood sample. Are you doing or planning to do GRS?
This would be fantastic, but not at the moment and not in the national program. Of course, I mean, I'm thinking to do at the same time in some district the genetic risk score in addition, but this is just because we're interested in research. Honestly, the genetic risk score applied to a nationwide screening is difficult unless to predict it as a newborn screening. So
Right.
since we do a number of genetic screening in newborns, it is, I mean, could be reasonable to add a genetic risk score at in addition to newborn screening in order to reduce the number, of course, of people to be followed by autoantibodies. You perfectly know all the topic. In our case in Italy, this would be complicated because since the newborn screening is done by law, you have to introduce into the law this possible screening. And this is, I mean, not easy to explain and to pass. Otherwise, I mean, I know that they are screening at birth a number of genetic diseases, apart from hypothyroidism, this is done by many decades, but you know, this cystic fibrosis and many other metabolic genetically determined diseases. So it's not impossible to include, but not in the near future, because we should, well, we can do as a research program, of course, but in order to make it systematically, we need to include in the law, and this is not, of course, by definition, is not simple.
No, it isn't simple, but I would add in the US that parents of children with SCID did lobby pretty hard in Washington and got the SCID test added to the newborn heel stick through their advocacy. So there's some hope.
Yes,
Well,
but it is different because, I mean, one thing is a genetic disease where you are searching for a SNPs rather than,
Yeah.
in our case, the genetic screening should be done in order to assess a risk of future and potential diseases different. I mean, also the ethic people, it's not easy to convince them about, or at least, of course, now the data are growing from this aspect, and the genetic risk score is much more accurate than in the past. So, I mean, it would be beautiful, honestly.
It would be a great tool for the field. Well, you have a lot of accolades in the chat. Peter Gottlieb and others, fantastic progress and congratulations. And thank you again for talking to us today. Hats off to all that you have accomplished in the field, and also just getting this massive project off the ground and running. It's really obvious that you're behind it and really committed to it. So thank you very much for all your work you've done, and appreciate your time talking to us.
Thank you. Thank you very much.
Have a great rest of your evening. Bye-bye.
Yeah. Bye to Jessica, Peter, and all the other friends.
Goodbye. Thank you, everyone.
Bye.
Thank you, everyone. Bye-bye.
Ciao.